Colleen Grogan, it's great
Go
to see
Colin.
you. I haven't seen you in a week. There. So who are you, and what do you do?
I'm a professor at the University of Chicago in the School of Social Service Administration. I do work on broadly health policy and health politics, and have focused for a long time on the Medicaid program, which I think we're going to talk about today.
Great, and I should say this is. I take it that this article that we're going to talk about is part of a book project, and maybe you could say a little bit about that.
Sure. Yeah. It definitely draws from the book project. The book is interested in understanding how it is that what I call the kind of rise of the conservative healthcare state, and so essentially we have a much more public system than we often acknowledge, and I think the growth of Medicaid is kind of part of that larger trajectory, that people are always surprised when they learn how big Medicaid really is, given that it's our healthcare program for the poor. We think we don't have that many poor people in America, but the program has kind of, its tentacles have moved in so many different directions to cover many different needy people. And our system, our larger system, is so fragmented that Medicaid has ended up over the years since 1965 until now kind of filling in those gaps. And I think Medicaid's a really important story, but I also think Medicaid is part of a larger phenomenon in the US healthcare system.
Just to kind of peg a few basics, like how many people are on Medicaid? Like how big is this program?
Yeah. Today, Medicaid covers 1 in 5 Americans, so 21% of Americans, and it's a program that responds to need. And so when lots of people end up unemployed, such as unfortunately today with the coronavirus, Medicaid's going to grow quite substantially, actually. So that's really important because Medicaid is there for us when something like emergencies happen. 2008, the program grew quite substantially. And then, of course, we expanded Medicaid with the ACA. So today, it covers 65 million people as of 2017. You know, it's that's up from about 40 million people in 2008. So that's a huge increase over just a decade. Yeah.
How do you think people would have, if we could take someone from 1965 and put them in a time machine and say, this is Medicaid in 2020, how, do you think they would be surprised to see Medicaid looking like what it looks like now?
They definitely would be. Even I think Wilbur Mills, who people have called him kind of the architect of Medicaid. He was a Democrat from Arkansas, chairman of the Ways and Means Committee from 1958 to 1974, often called the most powerful man in Washington, right? So he was the architect of Medicaid, and I think intended part of his strategy in enacting Medicaid back in '65 was to really diminish the need for national health insurance. And so he might be surprised, but I think he would also, rightly or wrongly, be probably very satisfied in some ways that Medicaid is still around, right? That was his strategy, was to forestall national health insurance. Now, he also probably never intended for it to get as large as it actually is. I mean, I think he wanted, his thought was employer-based health insurance would take care of the bulk of Americans. Medicaid would remain fairly small, and then of course we'd have Medicare for the elderly. And that basic structure has remained intact. So for him, he would probably be pleased that it's remained intact, and yet be surprised at how much employer-based health insurance has unraveled over the years, and the program to fill its place has been Medicaid.
It's sort of amazing how often Medicaid ends up being the safety net for whatever else is going wrong in the American healthcare financing system, be it disability, be it the unraveling of employer-based coverage. It's kind of the stopgap for so many other aspects of American healthcare that may not have been anticipated 50 years ago.
Absolutely, absolutely. I mean, I think again, the strategy for people favorable of, those who wanted national health insurance in 1965 thought it was imminent. And by 1970, we would have, we're doing Medicare in 1965, but by 1970, we'll have national health insurance. And in many ways, that did look very possible, when you looked at the number of pieces of legislation that was passed in the Great Society, the votes we had in Congress. But, quickly, by 1974, that that window of opportunity was gone, and we've really never had that window of opportunity to do something like Medicare for all from a political perspective since that time. And so, but in people's minds, they still think Medicare, if we're going to expand, it's Medicare. And I think ideologically, Medicare and sort of programmatically, Medicare in many ways does make sense, but it's always ended up being Medicaid that's expanded over time.
I find that so interesting, and how many politicians in both parties end up finding Medicaid useful for their practical problems that they have, and also a sense of accountability. If I'm the governor of a state, if I'm accountable for it. Medicaid is both the tool that keeps rural hospitals open, and it's also the thing that comes back to me if it's screwed up. And Medicare has the accountability is much more diffuse in that way. I mean, you couldn't cut Medicare. You would be killed if you cut Medicare, but it's not as immediate. There are fewer people who sort of say, "Wow, I have an immediate need to draw on this thing." The way that
no, absolutely. I mean, I think the intergovernmental financing of Medicaid has helped fuel its growth. It's a lot easier for the federal government to say, we'll expand Medicaid, but we will allow states to expand Medicaid, so they can show that they're being generous, but also say, politically fall back on federalism, which has always been hugely important in the U.S., and then allow it. I mean, the original mandate to do the Medicaid expansion in many ways was unprecedented. And I hate to say that, because I think legally it wasn't unprecedented. Mm-hmm. But typically the strategy from the federal government was to start with options, allow states to expand. And then once, you kind of had 2/3 of the states that had already expanded, they would turn it into a mandate. The Medicaid expansion just sort of went full throttle to the mandate. And I mean, we saw the results of that in the Supreme Court kind of pulling back. But I think politically that federalism aspect plays a huge role, because the governors do have an awful lot of discretion, and even more than they, today under the Trump administration than they did before, which we can get into with the work requirements and everything else. So.
Yeah, it's interesting what you just said. It reminds me of one of the points that you make. You sort of, Charles Dickens is kind of the overall structure, A Tale of Two Cities, in the way that your essay is formulated. And you said it's the best of times and the worst of times for Medicaid. And I wonder if you could give an example of the best of times and also the worst of times, that sort of to follow up on what you were just saying.
Yeah. I mean, it just, occurred to me when this was part of a special issue in JHIPL of, what does the ACA look like 10 years out, after one decade of the ACA, how do we sort of look back on things? And of course I wrote my essay on Medicaid. And when you look at the past 10 years, it really feels to me that it has these huge juxtapositions that you get, kind of the best of worlds and the worst of worlds. And so the best is certainly the Medicaid expansion. I mean, people had been fighting to get rid of the categorical eligibility requirements in Medicaid really from the very beginning. And what I mean by categorical eligibility requirements is that Medicaid always said, in 1965, the federal government said, Medicaid is a program for certain types of poor people. So it was never just, if you're poor, you're eligible. It was, if you're poor and you're a single-headed household, you're eligible. Or if you're poor and disabled, you're eligible. If you're poor and elderly, you're eligible. But if you're poor and an able-bodied, so-called able-bodied male, single male, you were not eligible. The whole kind of people who were homeless, who clearly had multiple, many people mental health needs or substance use disorder needs, were never eligible for Medicaid. And so when the ACA got rid of that categorical requirement and said, now anybody under 138% poverty is eligible, that was a huge, huge advancement for the program, because it meant these people that were for years and years considered sort of not deserving were now put in the category of deserving. And states have been really creative in terms of creating programs, so, housing first programs that they're using Medicaid dollars to pay for. And again, they have a long way and they're learning a lot. It's not that the homeless are, problem solved by any means, but states are actually really trying to grapple with this problem now that they really didn't in the past. And again, using Medicaid dollars to do that. So that I would put in the category of kind of the best, the best of times, right? Like these are things that we were hoping Medicaid could do. And, but then you have the kind of opposite of that, of states that just completely rejected this Medicaid expansion. It's only 14 states left today, so it's a fairly small number. But those of us, if you think back to the last decade, Medicaid has become very, very, very politically controversial. And it was one of the most fought about aspects of the ACA program, even though a number of Republican governors ended up supporting it. But when a number of conservative states passed the Medicaid expansion, they passed it, ironically, it's kind of hard to believe they could even do this, but they would pass the Medicaid expansion by arguing that they weren't actually expanding Medicaid. And they were very successful in doing this because they could say, this is a private initiative. We're relying on managed care plans, or, this isn't a government run program. We're developing the Arkansas way, or it's the Indiana way. And it was still drawing down federal dollars. It was still putting a lot of state dollars. So it was lots of public money to do this Medicaid expansion, but they framed it as a private initiative. And I think we're able to get it passed in these conservative states under that framing. And so that's okay. I mean, those people, a number of people still got coverage, but at the same time, they've been able to implement reforms that are based on personal responsibility of kind of forcing Medicaid recipients to pay premiums or pay copays and deductibles, to use a medical savings account, which sound okay to most Americans, and most Americans have to do that on private health insurance. But when you're poor, that can be really difficult to have to pay, to make those payments. And in a state like Indiana, if you don't make a payment, you're locked out of the program for 6 months. So a lot of people have been disenrolled from the program because of some of these policies. And it's not the more middle class families or working families that have ended up relying on Medicaid. It tends to be these really vulnerable groups, like the homeless or people that have being released from prison or jails, because their lives are very tenuous and very difficult, and it's hard to pay a premium or a copay or deductible. So I would put that in the category of kind of the worst of times, because it isn't just that people are being disenrolled, but they're creating a whole new ideology within the program. And that, I'm afraid, could be very long lasting. So while they've expanded the program, they've also bifurcated it, and they treat different people differently on the program. So instead of what I think the Medicaid expansion from the Obama administration, when it passed the Medicaid expansion under the ACA, I think they wanted, the ideology there was anybody that's under 138% of poverty is equally deserving on this program. And we want to get away from this notion of if you look a particular way or you have a particular problem, you're deserving, you're undeserving. But the conservative states have been able to keep that ideology intact, right? That no, they want different deserving categories. And so that to me is why those policies are even more important than the disenrollment itself, because they have these very long lasting footholds in kind of how we even think about the program and the ways in which we structure it. And then that has important, I think, political implications as well.
I was hoping that some of the things you just described would make it more attractive for the states to come in that are not doing the Medicaid expansion at all. The rebuttal to the argument that you just gave might have been on Earth too. You could say, well, that's what it took to get Florida and Texas and Georgia to do the Medicaid expansion, given the political values in those states. But what's so frustrating is that even with those types of accommodations, we haven't figured out a way politically to make it happen in those 14 states that you mentioned, where I think it would have to take on a more conservative cast, just given the realities of the give and take in American politics. But somehow we haven't. I was hoping the Trump administration would find a way to do that, with these states, and find a politically feasible way. But so far, it hasn't really happened. At least in the Deep South, it hasn't happened.
Yeah, it's kind of amazing in some ways, as you say, that it hasn't happened, because you would think for a conservative state wanting to draw down those federal funds, this is the best case scenario, right? They can draw down federal funds and yet implement a number of conservative policies that they were not allowed to do under the Obama administration. And arguably, if there's a change in the administration, they may not be able, I mean, that might be one of the, if we have a Democrat who wins the White House, work requirements, some of these more conservative reforms may not be allowed. I'm not sure. We don't know what will happen. But maybe that's part of their thinking is, well, sure, we'll pass it now, but 2 years from now, if there's a Democrat, these conservative policies that we really support, we won't be able to do anymore. Yeah. I don't know. I think the other logic in some of the Southern conservative states is that an a really high proportion of their population will be on Medicaid. I mean, in Arkansas, for example, I think it's at least a third of the population will end up on Medicaid. And so I think they do worry about, if these people vote, that it will be hard. They will have some political sway, and it will become a program that acts like an entitlement, right? Which is difficult to retrench.
We certainly learned that in 2017. And I mean, the big reason for the failure of the ACA repeal was that people, the community of people who rely on Medicaid were incredibly important core of resistance to ACA repeal. And I'm sure that included a lot of the people that you just described in the states that, and one thing, by the way, I would mention about the Medicaid expansion is, as you know, I'm very interested in disability. And one of the challenges in disability is that real life disability is a multidimensional and continuous thing. And then you have programs that give you a 0-1 answer. Are you disabled or not? And there's many people for whom that just doesn't work. There's sort of the older coal miner who has a bad back, who a little bit unclear exactly what you would say about is this person disabled? And the Medicaid expansion is incredibly important for people or someone who has an IQ of 75, who has some serious learning disabilities, but is in many ways doesn't conceive of herself as living with a disability, that's another group of people for whom the Medicaid expansion and all the people connected to those people, now you also, one of the things in your worst of times sort of anxieties is the role of private firms in a lot of aspects of Medicaid. And there's an ideological aspect to how healthcare is financed and delivered through healthcare organizations and so on. I wonder if that's also another element that that you have some concerns about that that you might want to say something.
Yeah. Um, I mean, I'm not so critical of managed care organizations in terms of coverage. I think we don't have, I think there have been a number of studies over the years that have shown that, you know, they've been inconclusive that basically, right, that there's no major difference between MCOs, managed care organizations, and fee-for-service kind of states just, you know, not using managed care organizations. So I'm not necessarily so concerned about that. What I'm concerned about is the political impact of MCOs. And what I mean by that is, I think there's three areas where MCOs are concerning politically. One is when states contract out with managed care organizations, it allows them to kind of hide the role of government. And so I think you have a number of, especially working families that rely on CHIP, on health insurance for children. There is some evidence, not a lot, because people just haven't really looked at this yet, but there's some evidence that when you ask families, you know, are you on Medicaid? They'll say no. But if you ask, are you on Healthy Michigan plan, which is the Michigan's managed care plan or managed care program for working families with kids, they'll say, oh yeah, I'm on that program and I love it, it's fantastic, but I get Blue Cross Blue Shield from that, right? And so that's important politically, because if you ask them, do you think, you know, should we cut the Medicaid program? Should we expand Medicaid or should we cut it? People who are actually relying on Medicaid through managed care plans are just as likely as people in private health insurance to support or not support Medicaid. So usually if you're on a program and you really like that program and it's important to you, your support for that program goes up, right? And that's why we get that entitlement effect of kind of, it's hard to pull back Medicare because people know they're on Medicare, right? Yeah. But that, I think, is getting lost, and it's part of, I think, the conservative strategy to make those political ties in Medicaid, to weaken those political ties, and I think they've been very successful. So, so you don't have the big coalitions around Medicaid that you might expect we should have given the growth in the program, and I think it's because they've been able to bifurcate it and kind of hide the role of government and get people to think that they're actually somehow they get Blue Cross Blue Shield. I mean, they do pay a premium, so it makes them feel like they're getting private health insurance just for kind of a good at a good price.
That's such an interesting and complicated thing, because part of it is that how much do we think of ourselves as so I'm on Medicaid because my child lives with a disability. You're on Medicaid because you're a single mom with really low income. Do I think of myself as in the same program as the program that you're in and have a sense of solidarity with you? Or do I say, no, wait a minute, I'm on it for a different reason. Not that I know that it's, at some level, I know that it's Medicaid. It's sort of like the argument, you know, keep the government's hands off my Medicare. It's not like people literally don't know that it's government. They obviously do, but there's basically saying I'm one of the worthy people on it. And don't mess with my thing to help these other people. And so it's a combination of the role of government and to what extent do we have a moralized view of who should be receiving these benefits. And I think of myself as being on it for a different reason, a different way.
No, I think that's really true. It's a combination of things, and those moral frames are really important in terms of how Americans think about the program, you know. And I think, again, I would like to see more studies on kind of the influence of framing on people's opinions, because I do think it matters. If you frame it as, you know, we haven't had many politicians really framing Medicaid as a broad coalition, as we're all in this together, to try to create those broader coalitions. That would be more kind of a democratic framing, right? And Bill Clinton did it back in the 1990s to fight against the block grant that the Republican Congress was trying to pass at that time. And it's hard to know, like, was it Bill Clinton's framing that saved the program, but they were able to forestall that block grant. But that's, I think Bill Clinton's framing stands out because it's fairly unusual for Democrats to frame it in this way, which is kind of surprising. Whereas it's not at all unusual for Republicans to frame it as the disabled person is deserving and the single mom is less deserving, and she's on Medicaid, whereas the disabled parent is kind of on private health insurance that the state subsidizes, right? So it's very different. But
I must say, I worry a lot about if we went to a block grant structure, that all of a sudden all these different constituencies would see themselves as fighting over a fixed pie. And I can
absolutely.
tell you, as you know, my Veronica and I, my wife, take care of her brother who's intellectually disabled. If there is a fight over fixed resources, we know very well that families like ours would fare very well.
Yeah.
And both because there's individuals with intellectual disabilities are connected to a lot of family members who are a powerful constituency, and also because Vincent's cute and cuddly. There's
Yeah. Yeah. Yeah.
there's no stigma attached to that. And all of a sudden, if we were fighting with people with addictions or people with other kinds of issues, or just people with really low income, it's kind of scary, especially because some of the sympathetic constituencies are also the most expensive. And so you could imagine, really, if you really had a fight over dollars, you could eat it all up with a few of the disability constituencies that, even though Medicaid's grown a lot as a program, we could have had a whole more nitty-gritty discussion about where the money goes within the program, and the elderly and the disabled are people who are consuming most of the money. So these groups that are politically marginal are also weirdly vulnerable because they're kind of not a profit center in the way that the other people are, and they also just in a lot of ways they're vulnerable, it seems to me.
No, absolutely. I have another paper with Ethan Park on kind of looking at different groups within the program and whether the degree to which you see some kind of positive feedback effects in Medicaid. But as the motivation for that paper, we raised that exact point, that at the time, repeal and replace was happening in Congress, and they were talking specifically about per capita caps, and the per capita caps were different for each of these categorical groups, just as you're talking about. And so it absolutely, the block grants, it's not just that they create this kind of global budget that's limited, that people really focus on, but within that, each group would be treated differently. If it's structured the way they were talking about back in 2017, you'd have a different per capita cap for each group. Now that makes sense, because as you said, the disabled and elderly are a lot more expensive than low-income families. So they should get a higher per capita cap, but what exactly those caps are will be really politically fraught, and does create the possibility for infighting among Medicaid eligible groups, as opposed to people coming together to say, no, we should all work together to increase the pie, the size of the pie, right? Or, so I worry about that too. I think that's been a continual problem from the very beginning in Medicaid, that the long-term care side of Medicaid consumes the vast majority of expenditures, and yet it's really poor families that are kind of more demonized within the program.
I always thought we should go to seniors and say, I feel so bad for you that you're stuck with this one size fits all federal program. What we really should do is let your state finance your health care, and we'll block grant it, and then you can benefit from all the innovation of having the full faith and credit of the state of Illinois behind your health care, instead of these federal bureaucrats. And I don't think that somehow, I'm not sure that as a sales pitch that would work. And then say, okay, well, you think so? You're a little nervous about that for yourself. Let's come back to think about these other people. But somehow it's okay for them. So I'm not sure that I would get too far in American politics with a proposal like that. Now, what do you think? By the way, as you look ahead, what do you think Medicaid's going to look like like 10 years from now, or what are some possible paths that Medicaid could take? I just during this conversation, I was wondering where you think it's going. Uh,
Um, that's such an important question and such a difficult question, because back in 2003, I wrote a paper with Eric Potashnik, and the title of the paper was, Medicaid is at a crossroads. And that was, 20 years ago now. And I still feel like Medicaid in some ways is at a crossroads, right? And in part, I think it's because it relies on federalism, and you do get these extreme, now I think, even though Medicaid has expanded so dramatically and has become so generous, it's actually more unequal than I think it was in many ways. And so, I just, and it in part it reflects our polarized society. So it all depends. Like, are we gonna, as long as we continue to be very politically polarized, I think the program will also continue to look very unequal across the states. Though some states will continue to see, I think, some really important reforms and potentially real innovation, and maybe Medicaid will begin to look, not all that different from, or maybe even in many ways it's more generous than private health insurance, right? So it's complicated. My larger worry is, I had always thought maybe Medicaid might be something like a stepping stone to national health insurance. And then again, I don't really see that anymore because it's so bifurcated. Mm-hmm. I'm worried about more broadly. I also thought, I think we were all, those of us who have been in health policy for many years, wondered, is national health insurance something that could be a possibility for the US? That feels less and less likely. I think now that we built the ACA on a fragmented system, so we built it on the notion that we have employer-based health insurance, we have Medicaid, we have Medicare, it feels like we've entrenched that system even more so. So one of your questions was sort of, how has Medicaid become so entrenched?
Yeah.
In some ways, the way I see it is more that our broader system has become so entrenched, right? And so it's just really hard to get rid at this point of employer-based health insurance and expand Medicare or Medicaid to fill that gap. It's hard. Medicare for All politically, as you've written about, and several other people, with the level of private interest in the healthcare system today, seems extremely, extremely unlikely we could ever get anything like that passed. But equally as unlikely that Medicaid would expand into something like national health insurance. So I think our existing system is really what we're going to have in the future, and hopefully we can some states can continue to make that look better and more equal. So I don't know. I wish I had better news than that, but that's how it looks like. That's what it looks like to me.
I think that's a very compelling analysis. I must say, I do, when I compare the Medicaid expansion to the state marketplaces, it's sort of an interesting story, because I think a lot of people thought the marketplaces would be the jewel of the ACA, and Medicaid expansion would in some ways be kind of the stepchild, and all these poor people be stuck in Medicaid. And in some ways the opposite has happened.
Yeah.
Where the Medicaid expansion has been politically much more resilient, and in many ways more successful. And my oldest daughter is turning 26 this year, and I must say, I don't really want to put her into an ACA marketplace plan. They're not that good, and they're not popular. And in places, particularly in rural areas, there's many places where they just have not been very good. And in fact, in weird ways, that's created resentment, because a lot of people are saying, my screw-up brother-in-law is on Medicaid and he's got better insurance than I do. I'm in this crappy marketplace thing.
Yeah.
And I do wonder if that is generative for some sort of a public expansion. You know, if you said to people, we're not going to take away your private health insurance, I think that's self-immolating as a political strategy. But if you said, you know, you're over a certain age, you can sign up for something which is not going to be called Medicaid, but you could imagine is similar in what it actually does, it would
Mm-hmm.
not surprise me if a lot of people found that to be quite attractive.
Mm-hmm.
And maybe it doesn't eliminate employer-based insurance, but it becomes something that people value highly. And then once enacted, like the ACA Medicaid expansion, it becomes radioactive to mess with. Uh,
Right.
and so there's so many possibilities. You know, who knows? Maybe
Yeah.
President Nikki Haley will take credit for giving people access to Americare, you know, which will actually look a lot like Medicaid, but of course won't be called that.
Right.
And
Absolutely.
I mean,
Absolutely.
it's I do think that one of the real lessons of this Medicaid story is that when a program solves practical problems for people and for elected officials, it gets a kind of resilience. And it's not necessarily, sometimes that resilience is harmful because it may entrench things that are negative aspects of the American healthcare
Mm-hmm.
system, but
Mm-hmm.
it
Mm-hmm.
does become entrenched.
Yeah.
And it would not surprise me if Medicaid, if there was some weird way that Medicaid was generative to of a growth in public coverage, even if it's not the vision of it that anybody has about how you'd want to do this, but it just becomes a path
Right. Right. Right.
doable.
Well, I mean, you raised the point about your daughter is really important because I do think this younger generation, it's becoming more and more unlikely that when they start out their careers, that they receive employer-based health insurance, right? And that was always the case that young people were much more likely to be uninsured.
Mhm.
But as employer-based health insurance has unraveled and employer-based benefits in general have become less generous, certainly on the retirement side as well,
Yeah.
I think a younger generation isn't necessarily, they're not going to have the same expectation for employers that our parents' generation had. And so it's an interesting point, right? Because the way they might the whole idea was we couldn't expand public insurance because the American public, it's way too stigmatized and the American public would never accept it. But maybe, if you have this whole younger generation that ends up being on the marketplace or Medicaid, really, if they shifted over to Medicaid. And it's done through private plans, right? So they're still getting MCOs, they're still getting private health coverage. They might be much more accepting of the idea that, yes, I have public insurance, and push politicians to make that insurance coverage better and more generous, because Medicaid certainly is not without problems. But that's a very different perspective than just like, no, I reject the idea of public insurance altogether. It's more, yes, I'll be on public insurance, but I also want it should be better. And I'm going to put pressure on my politicians to be accountable for that.
Yeah.
I don't know. That's an interesting possibility,
I also wonder, by the way, since obviously at the moment we're talking to each other in our houses, I'm in my basement bunker.
Exactly. I was thinking about the same thing.
I mean, I wonder about how a crisis like the COVID-19
Yes.
thing,
Yeah.
what kinds of, it may change people's opinions about a lot of things, one of which could be if Medicaid turns out to be critical for public health in the next year as we all deal with this crisis, or if Medicaid in some way falls short in some that you could imagine that there could be a very significant political impact that just comes from this national trauma that we are now experiencing.
Absolutely, yeah. And I think we've all been, I'm sure you have as well, we've all been talking so much to our friends and colleagues and family about, how should the government respond to this crisis? And one for sure is I hopefully people are realizing the importance of having a strong public health infrastructure, right? That's not necessarily Medicaid. That's different, right? That's like investing in the CDC and having local health departments have some capacity. But nonetheless, when people are going to get free tests, but if they're positive, they also need treatment,
Yeah.
right? And so Medicaid is absolutely going to have to play a really large role in this crisis. And And so it'll be interesting whether that again kind of changes the perspective of the program, as you just said, for better or worse. I think people certainly, even you have politicians saying uh, employers should expand paid sick leave, but this isn't the time to ask employers to expand paid sick leave. It's sort of like
Yeah.
they either had it or they didn't, and if they don't have it now, they're not gonna. That's an unrealistic expectation.
Yeah, at
But
the moment they're like, will we exist?
exactly, and so it might have people rethink like what should be the basic kind of social safety net that Americans should have, so that when we have a crisis like this, we have a little bit of a safety net for all Americans to fall back on. And I think part of what's been revealed is not just the shortages of ventilators and hospital beds and masks and all that stuff, but also just the serious holes in our safety net, has really been revealed. So we'll see if that changes people's perspective on the welfare state. I don't know.
By the way, I do think that there's the link between Medicaid and public health is a major blind spot. And also the way that social determinants are important for that. You mentioned at the beginning of our conversation, housing. You have all of these people who are homeless,
Yeah.
who are both vulnerable to COVID-19 and also could infect other people. And it does seem like a Medicaid housing effort that said, we've got all these empty hotel rooms right now. Let's find a way that we could pay to put people into that, to keep them housed and safe and also just socially distanced. That would be really important. It does. I mean, the local health department, it is a little bit crazy that if you test positive for HIV, that Medicaid covers so many things. But when we have outreach workers who are trying to find the people who may be living with HIV and do the critical public health work to deal with that Medicaid is not paying for a lot of that stuff.
Right.
And we have this colossus with $500 billion colossus. It should be doing way more for public health than it is, because the reality is that Medicaid is the dominant financer of so many social services. And if it's not engaged in public health, we know that a lot of stuff won't happen, because you just compare even an inner city safety net hospital to the local health department, and it's just an unbelievable difference in the level of resources
at
every level.
Right.
So I do think that Medicaid has to, that'd be a whole separate conversation. But
Exactly. I mean, and that's part of what I write about in the book as well, is just how, this kind of long struggle we've had in the US between the development of public health and the development of our healthcare system. And in the US, we are not only unique because we don't have national health insurance, but we're also unique because we've always thought of public health as separate from our healthcare system. And in many other countries, they're integrated, that it's not so separate, right? They integrate the two, but, our private providers, hospitals, as well as physicians, fought very strongly to make public health, to really make sure that was separate, that public health is about something different than healthcare, right? And we know that it is, but when they made that argument, it was more about turf and money, right? And that
it's something separate. And by the way, it's separate, and we should get priority.
Right. Exactly.
Well, I must say, congratulations on your book's project moving forward. I look forward to when to its completion and when you become rich and famous, when the book comes out. I will take credit for knowing you. But this has been a great conversation, and stay safe, and thanks so much for talking to me and for talking to Jay Hipple. I'm gonna stop the recording now.
It was a pleasure. Thanks, Harold.